So before we go into trigeminal neuralgia or neuropathy per se, so just a little bit, few anatomical caveats about the trigeminal nerve. So number one, it predominantly gives sensory supply to the face, the anterior half of the head, as well as the nasal and oral mucosa. So basically, it gives significant or almost a large proportion of the craniofacial cutaneous innervation is from the trigeminal nerve. Regarding to its motor supply, it's mainly the muscles of mastication, and the trigeminal nerve exits the pons via the lateral surface. And there are three major divisions of the trigeminal nerve. So if you look over here, we have the ophthalmic nerve, which is the first division. Then we have the maxillary nerve or the maxillary branch, which is the second division. Then we have the mandibular branch or the mandibular division, which is the third division. So each of the divisions of the trigeminal nerve exits via a designated foramen. So the ophthalmic division exits via the superior orbital fissure. The maxillary division exits via the foramen rotundum, and the mandibular division exits via the foramen ovale. So next is we do have different nucleus of the trigeminal nerve. So we have the primary sensory nucleus, we have the spinal nucleus, and we also have the motor nucleus. So when it comes to the spinal nucleus, remember that the spinal nucleus extends up to the C2 portion of the spinal cord. And that is why sometimes patients who have very high cervical cord lesions can actually present with a facial sensory loss. That is because the spinal nucleus or the spinal tract of the trigeminal nerve extends up to the C2 level of the spinal cord. So now coming to the patterns of sensory loss in a patient with a trigeminal neuropathy. So number one, we have intraaxial pathologies or extraaxial pathologies. So intraaxial pathologies are basically pathologies that involve the substance of the brainstem. For example, a tumor or a stroke or a demyelination. So anything that is present within the substance of the brainstem is basically called an intraaxial pathology. So when the trigeminal nerve is involved, in an intraaxial pathology, you have something which is known as a baklava helmet sensory loss or an onion peel sensory loss. So have a look at this image over here where I've highlighted. So here you can see that there will be a onion peel sensory loss. So initially the central part of the face, then progressively like onion peels, the remaining parts of the facial innervation tends to get involved. So this onion peel sensory loss or baklava helmet sensory loss is seen in intraaxial disorders where the trigeminal nerve is involved. But however, if the trigeminal nerve is involved in an extraaxial fashion, for example, in a CP angle tumor, so in that case, you're going to have a segmental or divisional sensory loss. So let's say you're going to have, for example, loss over the V1 segment, loss over the V2 segment, or loss over the V3 segment. Because these divisions occur after the trigeminal nerve exits the pons. So segmental sensory loss is for extraaxial pathologies, for example, a CP angle tumor, and intra onion peel sensory loss or a baklava helmet sensory loss is for an intraaxial pathology, like a stroke, demyelination, or an intraaxial tumor. And the oligodendrocyte-derived myelin myelinates the trigeminal nerve up to 7 millimeters after it leaves the brainstem. And this is the reason for its involvement in multiple sclerosis. And that's why the trigeminal nerve is very commonly involved in multiple sclerosis because of its the proximal part of it even after it leaves the brainstem is myelinated by the oligodendrocytes. Next, the motor supply of the trigeminal nerve. So primarily it supplies the muscles of mastication, that is the temporalis, the masseter, the medial and lateral pterygoids. Other muscles that are supplied by the trigeminal nerve, by the motor nucleus, is the anterior belly of the digastric, the mylohyoid, the tensor veli palatini, and the tensor tympani. And very, very important is the cornea is mainly supplied by the ophthalmic division of the trigeminal nerve, with an exception of an inferior crescent, which is supplied by the maxillary division of the trigeminal nerve. Now coming to trigeminal neuralgia, which is one of the most important cranial neuropathies that affect the trigeminal nerve. So this has an annual incidence of around 4 to 8 per 100,000 individuals. It predominantly affects middle-aged and elderly patients. 60% of patients are going to be female patients. And the onset is usually sudden. So usually the patient presents with certain bouts or clusters of attacks of trigeminal neuralgia. And these last for around weeks to months before remitting spontaneously. But however, usually recurrence is a norm. And because of the severe facial pain that is associated in trigeminal neuralgia, sometimes the patient winces in pain. So this wince associated with the pain has got the other uh, name for trigeminal neuralgia as tic dolorans. So this is an important MCQ question. So they can ask you what is the other name for trigeminal neuralgia. It is tic dolorans. What are the clinical features of trigeminal neuralgia? So there are excruciating paroxysmal facial pain. Predominantly, it affects the maxillary division. Predominantly affects the maxillary division of the trigeminal nerve. So the lips, the gums, the cheeks, and the chins can be involved. Very rarely, the ophthalmic division is involved. So usually, if you have an ophthalmic division involvement, you'll have to work up for a possible trigeminal neuropathy rather than a neuralgia. So you have to see whether there's any underlying structural cause for the neuralgia or neuropathy. Usually the paroxysm of pains lasts for a few seconds, and sometimes the patients may wince with pain. This is called a tic. That is why trigeminal neuralgia is also known as tic dolorix. And the classical feature of these pains is it is triggered by sensory triggers. So the patient washes their face, brushes their teeth, or the fan draft of air touches the face. These cutaneous triggers are very classical for a trigeminal neuralgia. As I mentioned, the bouts usually last for around weeks to months. However, they spontaneously remit. However, usually they tend to relapse over time. So as I mentioned, the cutaneous triggers can be because of washing the face, brushing the teeth, or exposure to a draft of air. Can even be triggered by even speaking, chewing, or even smiling. The usual trigger zones are over the face, lips, and the tongue. However, there is no objective sensory loss. So what does this mean? What does no objective sensory loss means? So when you have a trigeminal neuropathy, the patient will have an objective sensory loss. That means when you examine the facial sensations, the patient will say that there are decreased sensations on that particular side. But if you examine a patient with trigeminal neuralgia, they will have no facial sensory loss. Even though they might have cutaneous triggers and severe pain, they will not have negative sensory symptoms. That is numbness. So if a patient with trigeminal neuralgia has numbness or any negative sensory symptoms, it's actually you have to look for a trigeminal neuropathy. That is basically a secondary cause for a trigeminal nerve involvement. Maybe because of a demyelinating disorder or CP angle tumor, or you'll have to work it up. So remember that no objective sensory loss. If there is objective sensory loss, it is not a trigeminal neuralgia, rather it is a trigeminal neuropathy. So what is the pathophysiology of a trigeminal neuralgia? So here, basically, there is ectopic generation of action potentials in the pain-sensitive afferent fibers of the trigeminal nerve before it enters the lateral surface of the pons. So we have two types of fibers, not only the trigeminal nerve, but everywhere else. So you have the small myelinated or unmyelinated fibers which carry pain, and you have the large myelinated fibers which carry touch and proprioception. So here, because of some sort of compression or neurovascular compromise, the large fibers which carry touch and the small myelinated fibers or unmyelinated fibers which carry pain get electrically coupled together. So because it is electrically coupled, whenever the patient has any touch stimulus, that is your sensory triggers, it stimulates the large myelinated fibers, but because it is electrically coupled with the small myelinated or unmyelinated fibers, it triggers paroxysms of pain. So this electrical coupling is a pathophysiology of trigeminal neuralgia, and it is usually supposedly because of some sort of neurovascular compromise. That there is some vessel that is sitting over the trigeminal nerve and causing this abnormal electrical coupling. The most common vessel which is implicated in this neurovascular compromise is the superior cerebellar artery. Next common is usually some sort of tortuous vein. And that is why for medically refractory trigeminal neuralgia, the treatment of choice is a microvascular decompression, usually of the superior cerebellar artery. So what is the important differential diagnosis of a trigeminal neuralgia? Number one is a trigeminal autonomic cephalalgia. So trigeminal autonomic cephalalgia, like a cluster headache or a SUNC or a SUNA, can present with severe craniofacial pain. And actually, if you take trigeminal autonomic cephalalgias like SUNC, they can actually even have cutaneous triggers. But the cutaneous triggers in SUNC will not have a refractory period, whereas the cutaneous triggers in a trigeminal neuralgia will have a refractory period. So this cluster, basically, a trigeminal autonomic cephalalgia is an important differential. Next is a trigeminal neuropathy. So the question is, when do you suspect a trigeminal neuropathy? I already mentioned when you have an objective sensory loss or a negative sensory symptom over the face, that itself says that you might be dealing with a trigeminal neuropathy. Second, if you have a bilateral trigeminal neuralgia, usually trigeminal neuralgia is unilateral, but if it is bilateral, you have to suspect a secondary cause. If the patient is young, okay, usually trigeminal neuralgia is a disease of the elderly. But if the patient is young, that time you have to suspect a secondary cause or a trigeminal neuropathy. Next is if the patient has a non-paroxysmal pain. So usually trigeminal neuralgia, they have paroxysms of pain. Between the paroxysm, they are normal or they don't have any pain. But in a trigeminal neuropathy, they might have a dull, aching, non-paroxysmal pain on and top of the paroxysmal pain. Another important diagnosis is temporal arteritis. That is your giant cell arteritis. So that can also present with scalp pain and craniofacial pain. That is also important differentials because the treatment is different and it can be vision threatening. So, what are the investigations for a trigeminal neuralgia? So, it's a clinical diagnosis. The only role for doing neuroimaging is actually to rule out any sort of secondary etiology or any trigeminal neuropathy. So, but however, for a poor trigeminal neuralgia, for a pure trigeminal neuralgia, in MRI brain, there is a specific sequence called the cis sequence. So this cis sequence is very sensitive for looking for the cranial nerves. So if you have a look over here, this is an MRI brain axial view cis sequence. So here you can see that this is the trigeminal nerve. This is the trigeminal nerve, and near that you have the superior cerebral artery. So this cis sequence can be useful to establish some sort of neurovascular conflict. So whether the superior cerebral artery or the anterior-inferior cerebral artery is pressing over the trigeminal nerve. Next, the other role of an MRI is to rule out any sort of secondary causes of a trigeminal neuropathy. For example, a CT angle tumor because of a meningioma or because of an acoustic schwannoma or because of a metastatic brain disease. So that can cause a trigeminal nerve involvement. Next is a demyelinating disorder, like a multiple sclerosis. So this is the important role of a neuroimaging in a patient with trigeminal neuralgia. Routine blood investigations. If you're suspecting a temporal arteritis or a giant cell arteritis, investigations like a ESR, a CRP, or a temporal artery Doppler might be used. Next, what is the treatment of trigeminal neuralgia? So I'll remember that the first line management of trigeminal neuralgia is always medical management. If you can treat your patient medically, that is the best thing that you can do. The drug of choice is going to be carbamazepine. This is the drug of choice for trigeminal neuralgia. Other medications are oxcarbazepine, phenytoin, lamotrigine, baclofen, topiramate, and gabapentin. But be very careful in clinical practice. So remember that carbamazepine, even oxcarbazepine, phenytoin, and lamotrigine all have a risk of causing Stevens-Johnson syndrome as well as toxic epidermal necrolysis, which can cost significantly for your patient as well as for your own clinical practice. So what I routinely do where I was trained was we usually do a HLA testing for HLA HLA-B1502. So if the patient has a positive HLA-B1502, usually we refrain from prescribing carbamazepine, phenytoin, or lamotrigine, and we try our best with gabapentin and the other medications. However, if the HLA-B1502 is negative, you can confidently start carbamazepine. It's not a very costly investigation, definitely worthwhile and definitely cheaper than an admission for a Stevens-Johnson syndrome or a toxic epidermal necrolysis. So if your patient has a medically refractory trigeminal neuralgia, the next consult will be to your neurosurgery colleagues because there is definitely a role for surgical management for patients with medically refractory trigeminal neuralgia. The surgical procedure of choice is a microvascular decompression. It has a more than 70% efficacy rate, but however, it is an invasive procedure and it requires a suboccipital craniotomy. The next other procedures are a gamma knife radiosurgery. It is less invasive, but however, it is less effective as well. The most effective surgical procedure is going to be microvascular decompression. Next is a radiofrequency thermal rhizotomy, and the other is a percutaneous balloon compression of the trigeminal ganglion. However, these two procedures have a risk of causing a trigeminal neuropathy. So basically, the pain of the patient disappears, but however, the pain is then replaced by a numbness. So there's a very high risk of injuring the trigeminal nerve and replacing the trigeminal neuralgia with a trigeminal neuropathy, iatrogenic trigeminal neuropathy. Right. So that's about a trigeminal neuralgia. Now let's talk about a few caveats about a trigeminal neuropathy. So as I mentioned, trigeminal neuropathy, you're going to get objective sensory loss over the trigeminal nerve division or distribution. In addition to the sensory symptoms, remember that trigeminal nerve is not only a sensory nerve, it is a motor nerve as well. So you're going to have weakness, and the major weakness is going to be jaw weakness because the trigeminal nerve supplies the muscles of the mastication. So you're going to have a jaw weakness, and usually the deviation of the jaw is to the weak side. So whenever it comes to the cranial nerves, the deviation is usually to the normal side. So if you look at a facial palsy, the deviation is to the normal side. When you take a palatopharyngeal palsy, the deviation is to the normal side. Exceptions to this is the fifth cranial nerve and the 12th cranial nerve. So in the fifth cranial nerve, the deviation is to the weak side. And in the 12th cranial nerve or hypoglossal nerve palsy also, the deviation is to the weak side. Okay, so remember these points, very important clinical caveats. And another apparently very uh, mild lesion, that is basically numbness over the chin. That is a numb chin syndrome or a mental neuropathy. Can be very mild for the patient, but usually it has a very bad prognosis because usually a mental neuropathy or numb chin syndrome is a sign of an underlying systemic malignancy where there is metastasis to all the cranial foramen. So whenever you have a mental neuropathy or a numb chin syndrome in a patient with a known malignancy, a known breast carcinoma, a known thyroid carcinoma, or known solid organ malignancy, it is a very ominous sign. It's usually a sign of a metastatic systemic malignancy. All right, now let's come to the various etiologies of a trigeminal neuropathy. So as I mentioned, the trigeminal neuropathy can be both intraaxial and extraaxial. So intraaxial, it can be because of brainstem lesions like a demyelination, a stroke, syringobulbia, or intraaxial tumors like a glioma or lymphoma. Next, it can be because of preganglionic lesions, that is before the semilunar ganglion or the Gasserian ganglion. So lesions of the CP angle like acoustic neuroma, a meningioma, skull-based metastasis, chronic meningitis, or a carotid aneurysm, cavernous carotid aneurysm. Next is your trigeminal ganglion per se lesions. So your trigeminal neuroma, herpes zoster, and ENT infections which are spreading to involve the semilunar ganglion. Next, lesions of the cavernous sinus, because the cavernous sinus uh, holds the ophthalmic division as well as the maxillary division of the trigeminal nerves. The mandibular division over exits via the foramen ovale. It's not present in the cavernous sinus. So cavernous sinus lesions like cavernous sinus aneurysm or a cavernous fistula or a cavernous sinus thrombosis, thrombophlebitis can all cause a ophthalmic or plus or minus maxillary division involvement because they are present in the cavernous sinus. Next, peripheral nerve lesions of the trigeminal nerve, like a tumor, Guillain-Barré syndrome, Sjogren's syndrome, mixed connective tissue disorder, Hansen's disease, sarcoidosis, or sometimes drugs. And sometimes, if there is no identified cause, an idiopathic trigeminal neuropathy can also cause a trigeminal peripheral nerve lesion.